We can. All right. The next speaker is Dr. Brandon Sweat from Brooklyn Methodist. He's a medical oncologist and assistant professor of clinical medicine at Weill Cornell, and he will be talking about circulating tumor DNA. Cancer cells have nowhere to hide.
Great. Thank you, Dr. Ficara. So just want to make sure you can see my screen.
Yes.
All right, great. So thanks again. I think great discussion so far. I'm going to be talking a bit about circulating tumor DNA or ctDNA. The title is Circulating Tumor DNA, Cancer Cells Have Nowhere to Hide. This is really a rapidly evolving field in the world of colorectal cancer. As we'll see shortly, there's a lot of kind of promising data out there to support its use, but I think still a lot more to learn before we can kind of comfortably and confidently use it routinely in clinical practice. So just briefly going to talk about what ctDNA is, some of the clinical applications, some of the clinical trials that are have existed and ongoing regarding ctDNA, and then of course some of the challenges and limitations and kind of where we're headed with this technology. Just briefly wanted to go through kind of the staging and surveillance for colorectal cancers, particularly colon cancer. So we have our kind of early stage 1, T1, T2 tumors. A little more invasion is our stage 2 colon cancers with our T3, T4 tumors. By definition, no lymph node involvement. Our stage 3 cancers, again, by definition, have lymph node involvement. These are the higher risk patients for recurrence, and then our stage 4 patients, of course, have disseminated disease. Typically for stage 1 to 3, I mean, if it appears to be localized, we go ahead with surgery, just observe the stage 1s. For the stage 2, there's discussion, but most patients do not benefit from adjuvant chemo. We do use some kind of clinical pathologic risk factors to determine who may benefit from treatment. And pretty much all our stage 3 patients, unless there's a reason not to give it, will benefit from adjuvant chemo. And by and large, for stage 4, we talk about systemic therapies. How do we watch our patients after curative intent resected colon cancer? So we see them in clinic periodically, check in on symptoms. They get CAT scans periodically as well, typically a colonoscopy starting a year after their curative surgery. And then we have our biochemical surveillance, which is CEA. It's a tumor marker, essentially a protein that's made by the cancer cells, and we can kind of quantify that and use it kind of as a baseline in response to treatments. And then what we're focusing on in this talk is ctDNA. I think it's been widely adopted, at least in our practice, and I think across the country, but I still think there's some unanswered questions about how we can kind of use this information, what the implications are, and particularly in the kind of post-operative adjuvant and surveillance setting. So we'll get into some of that shortly. So what is ctDNA? It's essentially fragments of DNA from dead tumor cells that's shed into the bloodstream, and we can measure that. We can capture it in the blood with a blood test and get a ctDNA value, either negative or positive. It has genetic and epigenetic alterations or mutations that are reflective of the tumor, either the primary tumor or the metastatic site. And we consider ctDNA to be a liquid biopsy, so it's non-invasive, and you get kind of real-time insight into what's going on with the cancer status, ideally. When we look at the half-life of ctDNA, it's about 1 to 2 hours. It varies a bit, but it's a relatively short half-life compared to CEA, where we have the half-life of about 3 to 5 days. So the relatively short half-life, you get a kind of a snapshot of the dynamic nature of the tumor, kind of the real-time status of the tumor, and you could see why it would be an attractive biomarker for looking at residual disease and early relapse for our cancer patients. So there's several different types of ctDNA assays. There's the tumor-informed approach and the tumor-agnostic approach. So tumor-informed is just that. It's using the patient's tissue, either their biopsy specimen or their surgical resected specimen, and they look at the mutational profiling there and they compare it to that in the blood sample that's collected. And there's some evidence of more sensitivity compared to the tumor agnostic assay. But of course, it does require tumor tissue, so it is invasive. Cost can be a little higher. Turnaround time's a bit longer than the liquid-based assays. And it's typically used for minimal residual disease or molecular residual disease detection. When we have the tumor agnostic approach, so this is not using the patient's tumor, but it's using essentially a broad kind of predefined panel of mutations that we can compare to the plasma of the patient. Of course, does not require tumor tissue. Cost tends to be less, quicker turnaround time. But because it's not tissue-based, based on the assay you're using, sensitivity can be a little lower than the tissue-based. This has a bit broader application in terms of you can look at mutational or molecular profiling, look at certain resistance mechanisms. It's also been studied for cancer screening, so detecting cancer earlier, and as well as the tissue-based, MRD detection, which is where we use it predominantly. So just to rehash the main phases of care where we use ctDNA, so genotyping in advanced disease, so it seems to have high concordance with the tissue-based testing, quick turnaround time. We can look for actionable alterations that we can then decide whether or not targeted therapies may be effective for our patients. And also patients who have been on treatment for some time and they tend to not respond anymore, we can see, have they developed any resistance mechanisms? It's a fairly easy blood test that we can send off to look for any kind of new emerging mutations. Again, what we more commonly use is for detection of molecular residual disease. This is usually in the earlier stage curative intent setting. And what we'll see soon is it's clearly a very good prognostic marker. So we know that patients with ctDNA positivity tend to do worse, but we're not entirely sure it's predictive as of yet in terms of who may or may not respond to our treatments after surgery. And then early cancer detection. So this is patients, of course, not yet diagnosed. Of course, there's many different screening mechanisms. So there's one that's FDA approved, Guardant Shield, for average risk patients, and it detects kind of epigenetic and genetic changes that may suggest the presence of colon cancer at an early stage. Obviously, it's convenient, but there are some concerns about implementation kind of broadly. This is just a nice figure that shows the clinical scenarios where we can use ctDNA to our advantage. So we have tumor burden on the y-axis here. We have the clinical scenario on the x-axis. This lower bar is the limit of detection by ctDNA, which you can see is lower than the limit of detection by imaging on this top bar here. So if you go in the bottom corner here, as the patient is diagnosed and their tumor burden increases, passes the threshold for ctDNA detection. So this kind of phase in this first blue line here is where we can use ctDNA potentially for earlier detection of cancer in our screening. Once the tumor burden grows and they have overt disease, the clinical diagnosis, we see it on imaging. Patients are sometimes given neoadjuvant, more commonly with colon cancer, they go for surgery, and then with or without adjuvant chemo. And here's another opportunity where ctDNA may be helpful, is kind of escalation or de-escalation of chemotherapy or other therapies based on ctDNA status. As the tumor burden drops, in their kind of curative space, we can look at it for MRD assessment. Is there minimal residual disease that we're detecting? And then if patients do recur, we can hopefully detect recurrence earlier. And that's kind of this last blue line here. This is the window where we may see it sooner on biochemical ctDNA testing, not yet clinical recurrence. So lots of different areas in the spectrum of a patient's disease status where we can use ctDNA. And these are kind of the areas, again, where ctDNA may be helpful to kind of change treatment for patients. This is the current NCCN guidelines based on pathologic stage and what adjuvant treatment is recommended. And not to kind of bore you with the details here, but just wanted to highlight, if you look at the footnote at the bottom, it says ctDNA is a prognostic marker. However, there's currently insufficient evidence to recommend routine use of ctDNA assay outside of a clinical trial. De-escalation of care and treatment decision-making are not recommended based on ctDNA results. Participation in clinical trials is encouraged. There's another footnote that kind of boldly states ctDNA is not recommended for surveillance. And so that's interesting. We'll get into some of the data, but I think one of the reasons why NCCN hasn't yet endorsed this is because there's really not robust prospective randomized studies that show a clear survival advantage to using ctDNA to guide adjuvant treatment. So now we'll just touch on some of the clinical trials that we have some data for using ctDNA. Again, the realm is kind of MRD detection. Can we look for residual disease after curative intent surgery? Also, so that's more prognostic, but also more predictive. Can we use ctDNA to kind of guide treatment? Who may or may not need chemo, who would benefit from chemo? And there's some studies looking at ctDNA in the metastatic disease for patients who are on salvage treatments. Can changes in ctDNA kind of determine early on who's deriving benefit from treatment and who maybe we should switch up therapy? So this is the Circulate Japan study. The observational arm is called the Galaxy study. So this was a multi-arm prospective study, and what they looked at, so patients who had resected colon cancer, either stage 2 or 3, or resected metastatic disease. If they were ctDNA negative after surgery, they were de-escalated. This is the Vega study. If they were positive after surgery, they were escalated in terms of adjuvant treatment. That's ongoing, the Altair study. And then this is what we're going to focus on. This is the Galaxy study, which is just purely observational. And it checked ctDNA at certain pre-specified intervals, really to determine prognostically if it's helpful and also who may benefit from treatment after. So the takeaway is really that ctDNA MRD status is predictive of post-surgical outcomes in response to adjuvant chemo. This is some of the data from the Circulate Japan study. And you can see patients who were ctDNA negative, this is 4 weeks post-surgery, their disease-free survival was considerably better than those who were ctDNA positive, in the 90% disease-free survival range, and that's sustained if they were negative. So quite prognostic in this case. Looking at its kind of predictive value with adjuvant chemotherapy. So this is the ctDNA positive post-op arm on the left here. And looking at patients who were observed in the red line versus adjuvant chemo, clearly adjuvant chemo in the ctDNA positive patients does improve disease-free survival. But in the ctDNA negative post-op, so there's no detected minimal residual disease, we see really chemotherapy does not offer much of a benefit to these patients. So interesting, positive patients do derive benefit. The negative patients in the study really didn't derive much benefit. And then looking at kind of ctDNA status, they looked at 2 different time points, both 4 weeks and 12 weeks after surgery, so 1 and 3 months post-op. You can see the patients in the dark blue line here who were persistently negative, they tended to do the best. Slightly worse, but still good, was the patients who were positive post-op but converted to negative. And then those who did considerably worse were the patients who were negative and then converted to positive. Of course, that's an ominous sign. And then the patients who were positive at the onset and remained positive, they had the worst disease-free survival outcomes. This is the bespoke CRC study. So this was a prospective observational study, really trying to see whether or not ctDNA assays can inform adjuvant chemotherapy for our stage 2 and 3 colorectal cancer patients. So they had 350 patients with stage 2 and 3 colorectal cancer. ctDNA positivity at the predefined MRD time point was seen in 6.9% of stage 2 and 22.4% of stage 3, which makes sense, higher risk of having residual disease. And what they found was that ctDNA or MRD positivity was definitely associated with worse disease-free survival. And within the MRD positive group, those who got adjuvant chemo did better than those who were just observed. It was 18 versus 6.7 months. And again, those who were MRD positive, who were able to clear their ctDNA, 40% cleared their ctDNA at 3 months. They did better than those who remained ctDNA positive. But those who were negative throughout all of this did the best, kind of mimics what we saw with the Galaxy study. And they also found really no benefit of adjuvant chemotherapy in the MRD negative patients. This is the dynamic study. So this is for stage 2 colon cancer patients. Again, those are the patients who we tend to, more times than not give chemotherapy to unless they have certain high-risk features that we consider a course of chemotherapy for. But they asked the question, can ctDNA be used as a biomarker to determine which stage 2 patients would benefit from adjuvant chemo and who we could potentially spare, toxicity risk without really compromising recurrence risk. So it was a phase 2 randomized control non-inferiority trial looking at ctDNA guided management and the 455 patients, they were assigned 2 to 1 to have decisions made by either ctDNA guided or standard criteria that we use in the clinic. And in the ctDNA guided management arm, if they were positive, they would receive adjuvant chemo. And if they were negative, they were simply observed. What they found was that in both arms, the recurrence-free survival was fairly similar and good, as we'd expected in the stage 2 patients in the 90% range. But, looking at who received adjuvant chemo, only 15% of patients actually received chemo in the ctDNA guided arm, whereas in the standard arm, 28% did receive chemo. So basically similar survival advantage here with less chemotherapy in the ctDNA guided arm. And the conclusion here is that with patients with stage 2 colon cancer, ctDNA guided management was non-inferior to standard management with respect to 2-year recurrence-free survival. And there was also a reduced use of adjuvant chemotherapy. So, we're always trying to do what we can to improve efficacy, but we also want to be mindful of undue toxicity. And if patients really aren't needing it, we want to keep that in mind. This was the COBRA study, which had some interesting data, a small study, but it was for our resected kind of low risk stage 2A colon cancer patients who the physician decided did not need any adjuvant chemo based on their standard risk stratification. And they were randomized to either standard of care, which was active surveillance, or ctDNA guided treatment. So if it was positive, they would get 6 months of chemotherapy. And if they were negative, they would be surveilled like in arm 1. And in the patients who had ctDNA detected, 7 were in the surveillance arm and 9 were in the chemotherapy arm. And interestingly, when you look at rate of ctDNA clearance in the patients who did not get any chemotherapy in the surveillance arm, they had a higher rate of ctDNA clearance than the patients who received chemotherapy based on ctDNA positivity. So it was 43 versus 11% ctDNA clearance. Again, it's just looking at clearance. They weren't looking at kind of survival here, but what we're seeing is ctDNA may not be perfect in this case in terms of predicting who responds to chemo. So the takeaway here is that there was no improvement in ctDNA clearance after 6 months of chemo for patients with ctDNA detected following resection of stage 2A colon cancer. And this study actually closed early for futility and raises concern, like we said, that it may not be ready for clinical practice. So kind of defies some of the other findings, but an important, I think, point to make. This is the Dynamic 3 study. So this was recently presented at ASCO. It was a multi-center randomized phase 2/3 study that looked at adjuvant chemo, either de-escalation or escalation for stage 3 colon cancer patients using ctDNA. So these were stage 3, they had an R0 resection, they were candidates for chemotherapy, and they had ctDNA testing done at baseline. And prior to randomization, the oncologist would decide what standard of care chemo was recommended based on their stage 3 kind of risk stratification. And then they were randomized to either ctDNA informed management or standard management. And when in the ctDNA informed management group, if they were negative, they had de-escalation of the proposed chemo regimen. And if they were positive, they would be escalated. So here's their escalation scheme. And essentially, if no chemo was planned, they would get single agent chemotherapy. If they were getting single agent 5-FU or Xeloda, then they would get the doublet. If they were getting 3 months of the doublet, they would get 6 months of the doublet, or 3 months of a triplet, FOLFOXIRI. And if they were planned for 6 months of the doublet, they would get at least 3 months of the triplet. So essentially, is more chemotherapy better for patients who are ctDNA positive is the question here. And then standard management, they would just get the standard pre-specified chemotherapy. What we see is that in terms of recurrence-free survival, the standard management, which is this red line at the top, they actually had better survival outcomes than the patients with ctDNA-informed escalation. It was 52 and 48% for 2 and 3 year for the ctDNA, and then standard of care 61 and 52% respectively. So the takeaway here is that escalation of adjuvant chemotherapy based on the ctDNA status as a prognostic indicator did not improve recurrence-free survival compared with standard of care for stage 3 colon cancer patients. So, what it's telling us essentially is more of the currently available regimens that we have is not necessarily what we need. We, I think, need kind of better adjuvant treatment strategies than what are currently, in our repertoire. And just to highlight, I think we talked about this briefly in prior talk, but this is the Circulate US study. So this is open throughout the country. We have it open at Cornell, Brooklyn, and Queens as well. We've been fairly successful in accruing to this study. It's, again, asking the question about chemo escalation or de-escalation in the adjuvant setting based on ctDNA status. So it's for resected stage 2 and 3 colon cancers, not including stage 2A. Completely resected, MMR proficient, microsatellite stable. If they are negative, they get randomized to 3 to 6 months of FOLFOX or 3 months of CAPOX. If they were negative and in arm 2 here, they were just observed without chemo, just ctDNA monitoring. And then if they're ctDNA positive, again, the question is escalation better? So they would get the standard FOLFOX or CAPOX for 6 months, or the triplet FOLFIRINOX regimen for 6 months. So similar to what we looked at with dynamic, the results there were not as favorable. Curious to see what comes here, but this is kind of ongoing. And these I included just a few ongoing clinical trials looking at ctDNA and whether we can use it to inform kind of adjuvant treatment. So multiple countries, several different assays, largely in the stage 2 and 3 kind of post-operative curative intent setting. Can we use ctDNA to either de-escalate, escalate, or change up treatment somehow? And I think we all kind of eagerly await these results so we can have better informed treatment decisions for our patients. And ultimately the goal is to cure more patients with the stage 2 and 3 colon cancers. So then the question becomes, is ctDNA perfect? And I think the short answer is no. There are false positives. You can imagine a patient who has a positive ctDNA result, but no symptoms, and imaging looks good. They're sitting on a positive test, and it is not really a question of if, but when, they will recur, and that can be quite anxiety provoking. They may be subjected to unnecessary treatments. So ctDNA positivity, we tend to, if CAT scans look okay, maybe we'll get PET scans, MRIs, sooner colonoscopies, lots of other diagnostics and increased costs. And, we're not sure this necessarily improves the overall trajectory for the patient. False negatives too are a concern. Of course, you can miss and delay detecting recurrence. You can give false reassurance if the test is negative, but there is residual disease brewing. And then misguided treatment decisions. If you're using ctDNA negativity to de-escalate someone with a false negative test, that can have implications, of course. Some of the other kind of issues or limitations. So it's not standardized really from assay to assay. So collecting samples from different clinics, there's going to be different methodologies. Processing and analyzing these samples are not yet standardized. There's not really consensus about clinically relevant thresholds for what a ctDNA positive test means. And also, how do we use this information kind of in conjunction with the clinical and radiographic diagnostic testing that we have to date, right? So if there's discordance between the two, how do we reconcile that? I think that's still a question we need to answer. We know that tumor shedding varies among patients, extent of disease, tumor sites. So patients with earlier stage cancers tend to not have as much shedding. We know that peritoneum, for example, is notoriously a low shedding site. So if there's peritoneal disease and the ctDNA is negative, can we confidently say, obviously, they have disease, but we can't use ctDNA to assess that. And then of course, cost and accessibility, remains a concern. So I know I went through a lot, but just some key takeaways to drive home. We talked about some of the applications of ctDNA, so cancer detection, MRD assessment, which is what we chiefly use it for, and then molecular profiling, resistance mechanisms, et cetera. We know that ctDNA is strong prognostically. We know higher risk of recurrence post-operatively if they are positive. And it's emerging as a predictive biomarker. I think, there's ongoing studies, but we need to kind of, I think, still take it with a grain of salt until we get more robust data. It's also being used as an endpoint in, many clinical trial designs. It may lead to more clinical questions than answers. This is an important one. So I think, counseling patients, sitting down, what is ctDNA? What does a positive test mean? What does a negative test mean? And what are we going to do with this information? I think shared decision-making is really essential before you kind of embark on this as a surveillance modality. There's lots of studies we talked about, and then the bottom line is it has significant potential to hopefully alter our treatment paradigms, and the goal is to improve cure rates, cure more patients with earlier stage disease. And I think that's it. And I'll stop and just take some questions.
Great, thank you very much. This was very informative for me, at least. What resonated with me was your statement that when you said that the positive circulating tumor DNA may not be an indicator just to escalate the current therapy, but rather think outside the box and perhaps indicate that we should go to different, rather than 5 a few to doublets or triplets, just to think outside the box, perhaps as an indicator of a tumor biology that is not favorable, and we should be looking in a totally different direction. I think that's we'll see more and more of that. Unless there are questions from the other panelists, I will.
I have a question.
Yeah.
Just Brendan, if you first of all, I really enjoyed it, and if you might share, like, are you using it in every? I know what the NCCN guidelines say, but are you using circulating tumor whenever possible in those earlier stages 2 and 3? How are you using it, even if more data might be helpful?
Yeah, no, great question. And my practice has been I typically offer it, and I typically get it unless a patient does not there may be a patient who just doesn't want to know, or not, wants to wait till there's more mature data out there. But for most of my patients, I'm a little reluctant with the stage 1, but certainly the stage 2 and 3 patients, I think it is prognostic, and I think it can be helpful as we get more information. We'll be able to use that hopefully to tailor treatments. But nonetheless, I think for cancer, we still have a long way to go in general, and more information is better. So we can be empowered with our patients, I think, to to pursue further diagnostics if a test is positive. And I had a patient with, a positive ctDNA test. His scans were negative, got a PET, there was a small liver lesion that lit up. So, is this going to change his overall survival? I don't know the answer to that, but we detected recurrence earlier. We can do local regional. So there are helpful tools. And I think, I tend to use it more than not for my earlier stage patients.
Great, thank you.
Alessandra, we can't hear you.
No, I said thank you very much again. Great talk. We can stop the recording and move to the next speaker.